cancer run in your family?
Knowing your detailed family history and new advances in genetic testing can save your life. We'll discuss this important and life-saving issue on this week's Health Talk.
Stay tuned. We are up next. Welcome to Health Talk. I'm Dr. Vicki Smetak.
And I'm Dr. Eric Mazur. Today we're going to talk about advances in genetic testing. Our guest is Dr. Adam Ofer. He's an OBGYN physician with the Avery Center. Dr. Ofer is also Director of Gynecology at Norwalk Hospital.
Hi, Adam. Welcome to Health Talk.
Hi. Thanks for having me.
So what a fascinating topic. There have been so many advances in genetic testing in the past 10, 15 years, I would say. How is that impacting clinical practice and in the field that you're in?
You're right. There are incredible advances, and I think we're at the tip of the iceberg. We're at a revolution right now. I think the days when a patient walks into my office as a gynecologist and every patient is essentially the same is done. The day when you come in and you get a pap smear and a pelvic exam and a breast exam, those days are quickly coming to an end.
Yeah, we hear this term personalized medicine, and as you said, we are just beginning on a transformational change in the way we deal with patients.
We're just beginning, but it's there. I think a lot of patients don't realize we've got some incredible tests that are available, they're readily available, they're covered by insurance, and they can save your life. But the only way that the doctor really has a window into your genetic makeup right now is your family history.
Explain what that is. You know, we talked about that in the introduction, but explain in some detail, what do we mean by family history?
Right. So family history is, we need to be aware. We need to talk to our sisters, our brothers, our parents, our grandparents about what's in our family. Is it heart disease? Is it breast cancer? Is it pancreatic cancer? Is it colon cancer? In my personal family, it's heart disease. My father had a heart attack at the age of 50 that nearly killed them. So I know what I need to look out for when I go to my doctor. I need to talk about my cholesterol and heart disease. But if you've got a family where there's breast cancer or ovarian cancer, then that's a completely different topic. And in today's world, we can look at your genetic makeup. We can look for genes that can make you high risk for these cancers. And we can find out if you have the same risks as your parents or grandparents. And the best of all is, we've got ways now that we can intervene to reduce your risks.
I think that's really the key, is that we know today, for example, take heart disease. My dad had a heart attack at 58. High cholesterol runs in our family. We've got drugs that can reduce cholesterol dramatically. And so, you know, I'm running a very different, and I know not to smoke. I run a very different risk than my father did, and I'm well past the age where he had his heart attack.
Right. So what I hear from patients all the time is, if you start talking about genetic diseases, if you start talking about, let's say, hereditary breast and ovarian cancer, a patient will quickly say, I don't want to know about that. Because we were brought up to think, well, that's just a death sentence and there's nothing you can do. But that's not true today. There are very simple interventions we can do to significantly reduce people's risks.
Tell us a little bit more about these genetic markers, Adam, specific to the cancers that you just mentioned.
Yeah, so look, obviously we could talk here for hours and hours about genetic markers. The two biggest things that I deal with as a gynecologist and that I would hope we'd focus on today is the BRCA gene, which is hereditary breast and ovarian cancer. And what we also see a lot, which is very undiagnosed and probably not spoken about enough, is Lynch syndrome, which is basically hereditary colon cancer.
And these are really common cancers. So we're not talking about markers for rare cancers. These are important markers for common cancers. Not that everybody who has the cancers has these markers. Maybe you want to say a little bit about that.
Absolutely. Look, so a lot of cancers are random, right? A lot of cancers are caused by random mutations, by environmental factors. But when you start seeing a trend in a family, if you've got several family members who have cancers in these syndromes, you really need to start thinking about the hereditary cancers. So for example, if you have 3 women in a family that have breast cancer, that's not normal. That puts up a red flag. That has to make you start thinking about hereditary breast and ovarian cancer. It also has to do with different ethnicities. For example, Ashkenazi Jewish population has a significantly increased risk for carrying hereditary breast and ovarian cancer. So if you have a Jewish patient, if you're Jewish, and you have only one person in the family with breast cancer, that's enough to put up a red flag and at least talk to your physician about testing to see if you carry the gene.
Again, going back to the importance of the family history, right? If you're not, so this is why, and I think it's important to point out that it's the responsibility. It's kind of a two-way street, right? I mean, it's up to the physician to ask the questions, but I think it's equally important, right, for the
Absolutely.
patient to be forthcoming with all that very important information.
You're right. It's a two-way street. We as doctors need to change our mentality. I start looking now at family history, not as that last little thing we need to check off.
We were talking about that before
Right.
the show.
Family history to me is a symptom like anything else.
Right.
So if a patient walks in and her main symptom is that she's got bad cramps with her menses each month, but I give every single patient a family history questionnaire, and if she has what looks like a tendency for a certain cancer in the family, that screams out to me as a symptom. That's something that's worth spending some time on. And the flip side is, patients can really do themselves a huge justice by coming prepared.
I was
Talk
just
to your
going to
family
suggest,
members.
what can they do?
Sure.
They can make sure
Look,
they
we
know.
all know Aunt Millie died early of something. We don't really know what. You need to talk to your parents. You need to talk to your grandparents. Find out about family history. Keep a log of it. Share it with your children. You know, we need to keep this for generations, because we're not at the point yet where we can wave a magic wand and say, okay, here's your exact genetic makeup and here's exactly what you're at risk for. We need to be more targeted. We're not going to check you for every gene. And the only window I have as a physician to understand what you're at risk for is your family history. I have no other tools.
Then you mentioned early, and I think it's not just how many relatives, but the age at which these cancers came on. Maybe you could say a couple of words about that.
Sure. If we think about it, at least in general terms, everybody has a risk of cancer, but cancer under the age of 50 is very rare. For a woman to get breast cancer is not that uncommon. More than 10% of women will get breast cancer at some point in their life. But breast cancer less than 50 should be a big red flag. Colon cancer less than 50 is a big red flag. Endometrial cancer less than 50. People really shouldn't be getting cancers less than 50, and that in itself should be a giant red flag to think
So
about.
if you have a relative, close, particularly a first-degree relative, a sibling, parent, who
Right.
has early cancer, particularly colon, breast, ovarian, that's really you should be evaluated, period.
Keep in mind, even just ovarian cancer. So if you look at someone's family history, even we as physicians, if the only thing on a family history questionnaire shows that a patient had an aunt with ovarian cancer, it's tempting to say, that's probably nothing, it's just one aunt, there's nothing else. Ovarian cancer is extremely rare, and 10 to 12% of patients that have ovarian cancer actually carry the gene for hereditary breast and ovarian cancer. So if you have even just one aunt with ovarian cancer, nothing else, that still justifies looking into your family and seeing if the gene exists there.
So-
We have some slides you brought along, and maybe we can bring these up, because they show us these relative risks, and you can walk us through and to help our viewers at home and to explain to us what we're looking at here.
Yeah. So for women who carry the BRCA or hereditary breast and ovarian cancer mutations, and it gets more technical, there's BRCA1 and 2, but for our purposes, we can stick to general. These women have up to a 90% lifetime risk for developing breast cancer and up to a 45% lifetime risk for developing ovarian cancer.
So the red bars are actually showing us the risk with the gene, and the gray bars are the general population.
Yes. But what really is striking, if you look all the way to the left at that red bar, up to 50% of BRCA patients will develop breast cancer before the age of 50. That's before they've seen their children get married, before they've seen their grandchildren. That's where the big impact is.
So let's take a look at the next slide.
The other thing to really think about is BRCA mutations in men. A big misconception is that this only affects women. But actually, men can develop breast cancer. They have an 8% chance of breast cancer in their lifetime, which is way higher than the general
breast cancer,
population
a lot of people don't even realize men can get breast cancer. And here we're talking about almost 1 in 10.
Not only can they, but if you have that in your family history, see red giant flags and blinking lights and bring that to your doctor, you must discuss
So if your
that with your
brother
physician.
or your father died of breast cancer, you should probably be evaluated for
It's
this gene.
just not normal. You must be evaluated at that point. And prostate cancer. Prostate cancer is fairly common among men, 14%. There's almost twice the chance of developing prostate cancer if you carry a BRCA mutation. And there are also just some lesser known cancers. Also pancreatic cancer is associated with BRCA mutations, and so is melanoma to a lesser extent.
Now Lynch syndrome, that isn't another mutation. And so maybe you could walk us through this.
So Lynch syndrome is, for some reason, doesn't get a whole lot of press, but it's just about as common as hereditary breast and ovarian cancer. Lynch syndrome increases women and men's risks for developing colorectal cancer. For women, it increases the risk for developing endometrial cancer and ovarian cancer. So here we're looking at colorectal cancer risk by age 70. In the general population, there's only a 2% risk. But if you carry this gene, you have more than an 80% chance of developing colorectal cancer.
Yourself from dying of that by getting a regular colonoscopy and knowing this.
But it's very different, right? We all should get regular colonoscopies. The recommendation is over the age of 50, right? But there are several factors. If you carry this gene, you can develop cancer earlier.
Right.
It tends to be on the right side of the colon, not just the left side of the colon. And the big difference is this. It develops from nothing to a polyp to cancer in 1 to 3 years.
And let's look at the next one. So you get more frequent colonoscopy if you carry that
More
gene.
frequent colonoscopies can and do save lives.
And this is
So the general concept is you have up to a 70% chance of endometrial cancer if you have this gene, and up to a 12% chance of ovarian cancer if you carry this gene. And again, if you look, 20% of those patients develop endometrial cancer less than the age of 50. So we as doctors, if we see endometrial cancer less than 50, we better think about this gene. And if you as a patient see that in your family history, you better think about it.
So take us back to the office then Adam. You have a patient, let's say, who comes in 45 years old. Aunt Millie has had ovarian cancer. How do you approach that patient? What happens in real time?
So if I see a patient, there are very strict criteria for us as physicians as to who meets the guidelines. I usually go with the NCCN, National Comprehensive Cancer Network. The guidelines are online. Anybody can go in and take a look at them. If a patient meets criteria that they should be tested, we have a quick conversation. I don't want to scare people. I say, look, your family history indicates that you may be at increased risk for ovarian cancer, and you may be at increased risk for carrying the gene for ovarian cancer. There's a very simple test we can do before you even leave the office. It's not even a blood test. We can swish around this scope in your mouth. They get DNA from it.
I was just going to ask about that. Just it's really nothing terribly shouldn't say sophisticated. Invasive for the patient. It's nothing.
It's incredible. They literally swish scope in their mouth, spit into a container. We send it off to a lab. If they meet the correct criteria, it's almost always covered by insurance. If it's not covered by the insurance, then the company calls them. It's not just run, and they come back to my office to discuss the results. I'm a physician. I don't have the time to sit there and talk about every possibility then, but every patient comes to my office to discuss the results. And what's really important to remember here is if you have a family history for one of these things, let's say ovarian cancer, and your genetic testing comes back negative, it doesn't mean you're off the hook. There are many reasons for people having cancer in the family, and you still have a familial risk. And we as physicians still have ways of reducing those risks. So even that patient who has a family history of ovarian cancer, if she's negative for the BRCA gene, we still can do yearly transvaginal ultrasound, CA-125 blood tests. We still can significantly reduce her risk just because of her familial risk.
So you increase the level of surveillance, basically, customized to that patient's
Absolutely.
history.
So genetic testing is one part of it, but all patients need extra surveillance.
And this is really a major advance in the prevention of terrible disease over the past decade and a half. And I think people are just realizing this amazing power that we have to prevent these devastating diseases, because they're often such young patients. And actually, we're going to meet one of these young patients in the next segment, one of your patients who's been very brave, and she's been willing to share her story with us. So I want to thank Adam, and Vicki and I will be back with Adam and his patient after this short break.